itself. It's almost like this free margin. Posteriorly is attached to the top of the arytenoid. And then anterior, it's a little bit more floppy. But when we look at the false vocal cord, the key radiological findings are the follows. Number one, this red line right here demarcates the level of the false vocal cord on a coronal CT. So right below it, we can see one laryngeal ventricle and the other laryngeal ventricle. So it's above the laryngeal ventricle. Next, notice this red line is going right at the top of the arytenoid cartilages because this is where this tissue attaches to posteriorly. So when we're looking at an MR scan or a CT scan, how do we know we're at the false vocal cord? Because we can see the top of the arytenoid cartilage. So if you see the top of the arytenoid cartilages on an axial images, then we know we have to be at the level of the false vocal cord. Another image here, this was a tumor that was involving the larynx, and notice this yellow arrow shows the top of the arytenoid cartilage. So when we see the top of the arytenoid cartilage, we know we have to be at the level of the false vocal cord. So I want to go back one image. Aryepiglottic fold is paramidline, but there's no cartilage seen at this level. False vocal cords are also paramidline tumors, but notice here, you can see the top of the arytenoid cartilage. So conceptually, that's the hardest one. If you remember that, if you can just remember that, then you'll always be able to identify the false vocal cords. And really, for me, everything else in the larynx becomes a lot easier. So we talked about the false vocal cord, and what I want you to do is take a look at this line here and this line here. So now things get much easier because that red line all of a sudden jumps across the laryngeal ventricle, and now it's located at this level, which is the cricoarytenoid joint. So this is the famous cricoarytenoid joint that identifies the level of the true vocal cord. So this is what we see on axial images. Here's the cricoid cartilage, here's the arytenoid cartilage, the cricoarytenoid joint, true vocal cords. And at this level, the yellow arrow points at a tumor involving a part of the larynx. Now, where in the larynx is it? Well, let's look at our radiological landmarks. Here's the cricoid cartilage, here's the arytenoid cartilage, and look at it, it's kind of smiling at you. It's kind of got Akshay's lovely smile, right? Akshay and Vasi's lovely smile. It's just smiling at you right here. So when it's smiling at you and you can see the little incisure of your lips right here, you know you're at the level of the true vocal cord. So our radiological landmark is going to be the cricoarytenoid joint. Why do we call it the cricoarytenoid joint? Remember the big five. And then on the axial images, we can see the little smiley face right here telling you you're at the right level. And then the last primarily an anatomy of the larynx is going to be the subglottic larynx. Now, what we did is that we went from the false vocal cord, we jumped over the laryngeal ventricle. We'll talk about this later. We came down to the true vocal cords. Now we're going to go below the true vocal cords, and the subglottic larynx is formed, as I mentioned before, by this big signet ring, very thick cartilage, and that is the cricoid cartilage. So when we look at the axial images, instead of the person smiling at you, if you can imagine this as a mouth, and now someone's really surprised. It's like the emoji of the scared emoji or the surprised emoji. And instead of having this nice little smiley face and this triangular airway, instead now we have a big round airway. And this is the normal appearance of the subglottic larynx. And the reason why it's so large like this, it's so large like this because that cricoid cartilage is so big. And just attached to it here is the mucosa adjacent to the cricoid cartilage. And this is an example of a patient that has a squamous cell carcinoma involving the subglottic larynx. And the reason these patients present with stridor, and we'll talk about this a little bit later when we talk about infectious processes, is that it narrows the airway right here. So this tumor right here is circumferentially involving the subglottic larynx, and notice how it's narrowing the airway, and this is why patients get the stridors. So what we've done so far is that we talked about the different levels. We talked about the epiglottis, we talked about the aryepiglottic folds, we talked about the false vocal cords, we talked about the true vocal cords, and we talked about the cricoid cartilage. The reason why we hit that anatomy so hard and we focus on the radiological and landmarks is because when you are dictating patients that have a tumor involving the larynx, you realize 80% of these tumors are going to be seen at endoscopy. They're going to be able to see these tumors. So if your report just says there's a cancer involving the larynx, you haven't done anyone any good. What they want to know, first of all, is to figure out where the tumors are rising from. And that's why we went over all of these specific radiological landmarks. But the next thing they want to do is provide information that they cannot see on clinical examination that you could see on imaging. And I'm going to go over the 4 or 5 things that I include in my report, and you can decide whether or not they're important for your practice. But these are the 5 things that I include in my report, and I'll emphasize why they're important over time in the clinicians that I've worked with. So the first thing is subglottic spread. What is subglottic spread? Well, subglottic spread purely means that if you have a tumor that's involving the true vocal cord and it extends inferiorly, that means it's extending into the subglottis, hence the term subglottic spread. So let's take a look at all the anatomy we learned. Here's the cricoid cartilage, here's the arytenoid cartilage. And if we were in a live workshop, I would ask you what level we're at. I'm sure you know it. Cricoarytenoid joint, we're at the level of the true vocal cords. So here's a tumor that's involved in the true vocal cords. And when we look inferiorly, notice we don't have a cricoarytenoid joint, but we can actually see now the cricoid cartilage. This now is extending inferiorly. So this is an example of subglottic spread. Why is it important? Because if there's greater than 6 millimeters of subglottic spread, it's generally felt that the only way that the surgeons can do a complete resection is going to be a total laryngectomy. Now, some places, especially in Europe, are still doing extended partial laryngectomies. There's been some debate as to the actual functional outcome of these patients. The tumors can be resected, but how much of that larynx is going to be functional? I think that's somewhat debatable. So the bottom line is that if you see a patient that has a true vocal cord carcinoma and there's more than 6 millimeters of subglottic spread, well, this, in many cases, the only surgical option is going to be total laryngectomy. In actuality, in real life now, a lot of these patients are being treated with chemotherapy and radiation therapy. So we as a radiologists in these situations have moved a patient from a surgical approach in many institutions to a non-surgical organ preservation approach. That's a very, very big thing that we provide our patients. The next thing that we're going to talk about is transglottic spread. Now, what is transglottic spread? Well, let me put it this way. One of my fellows, I've been reading out with my colleagues in Tanzania. I don't know if they're on the line or not, but for the last 4 or 5 years. And I explained this to them, and they said, well, Dr. Mukherjee, why do they call it transventricular spread? And you know, they are right, because what transglottic spread is defined by a tumor crossing over the laryngeal ventricle. So it's not necessarily crossing over the cords, but it's crossing over the ventricle. So if I did have to rename it, I would call it transventricular spread, but we use the term transglottic spread. So what is transglottic spread? Well, transglottic spread is when a tumor involving the supraglottic larynx extends inferiorly and it traverses the level of the laryngeal ventricle to involve the subglottic larynx. So here's an example of a tumor involved in the larynx. I draw a line down the middle, compare the right side to the left side, and I think I can convince you there's a tumor right here. Now, where is this tumor located? Well, let's go over the logic. Is this midline or paramidline? Well, it's paramidline, right? The next thing is that do we see any evidence of a top of the arytenoid cartilage? There's no arytenoid cartilage. So as a result, at this level, we're at the level of the aryepiglottic fold. So this tumor is involving the supraglottic larynx at the aryepiglottic fold. Now we look at this level. Here's the cricoid cartilage. Here's the arytenoid cartilage. We have the cricoarytenoid joint. Notice there's no tumor here whatsoever. So this tumor has not involved the true vocal cord. So as a result, this tumor is above the laryngeal ventricle. It's not involved in the true vocal cord. And as a result, this is purely in the supraglottic larynx. So there is no evidence of transglottic spread. Why is that important? Because it subcenters based on the size of the tumor, patient preference, so on and so forth. This patient would be a candidate for resecting the structures of the supraglottic larynx, and we called this a supraglottic laryngectomy. Now, this is a case I saw, again, about 30 years ago. I like to show these older cases because the surgeon at the time was thinking about operating on this patient. They actually almost did. But when you look at this, this is a tumor involving the epiglottis, right? Because it's anterior and midline. Now, what level are we at? Well, this is the cricoid cartilage. This is the arytenoid cartilage. Now, this patient had a bit of a muffled voice, but the surgeon thought that there was not any tumor involving the true vocal cord when they looked in the office. But I looked at this and I said, well, Dr. So-and-so, I think there's tumor right here involved in the true vocal cord. Well, they were still thinking about doing a supraglottic laryngectomy, but they took the patient to the operating room, and lo and behold, there was tumor involved in the true vocal cord. So as a result, this patient was not a candidate for a supraglottic laryngectomy. The only type of surgery that they could have would have been a total laryngectomy, but because of this involvement at the true vocal cord, which was all submucosal at the time, this patient was treated with chemotherapy and radiation therapy. So we make a big difference. Now, transglottic spread can also go from inferiorly to superiorly. So before we sort of talk about, if you will, gravitational forces going from the top to the bottom, now we're going to talk about anti-gravity. So you can have tumors involved in the true vocal cord, and they can actually extend superiorly. So here, what level are we at? We're at the cricoarytenoid joint, and we see a tumor here involving the right true vocal cord. Now, what level are we at here? One arytenoid cartilage, the other arytenoid cartilage, we're at the level of the false vocal cord. If you look anteriorly, there's a little air on the right, air on the left. This is the laryngeal ventricle. And with the leap of faith, you can actually something that we don't see as much as we used to when we were doing thicker sections. When we do thinner sections, it's kind of hard to see. But these are the paralaryngeal fat plane. These are my nice little tiger stripes. And what we can see here, they're symmetric. So there's no tumor extending up along the false vocal cord. So this is no evidence of transglottic spread. As a result, this patient could undergo some type of partial laryngectomy at the true vocal cords. This is what we refer to as a hemilaryngectomy. And what about this case? Here's a tumor that has involved in the true vocal cord. What level are we at here? Well, there's the top of the arytenoid cartilage. There's our friend. So we're at the level of the false vocal cord. You're all lying down the middle. Compare the right side to the left side. On the left side here, we see white, we see black, we see gray, we see black. These are my normal tiger stripes on the left. And on the right-hand side, what we see is the soft tissue mass that's extending superiorly along the paraglottic or the paralaryngeal fat at the level of the false vocal cord. So this tumor has extended superiorly, and if they tried to do this type of surgery, they would get a positive margin. So when we see situations like this, they're still relatively low volume tumors. These patients, if they try to do a hemilaryngectomy, they're going to have a positive margin. Really, the only surgical option is going to be a total laryngectomy. But when we see this type of spread, at least at the institutions where I work, these are now going to be treated with combined chemotherapy and radiation therapy in most of those institutions. So again, all submucosal disease, but we make a huge difference. So from my standpoint, subglottic spread and transglottic spread were the tough ones. Now it gets a little bit easier. So when we look at the next key element, I always like to look for cartilage invasion. Now, when I look at cartilage invasion, I can do CT or MR. In the United States, we do a little bit more CT or a lot more CT than MR. I know in Europe, they do a lot more MR than CT. So part of it is, your preferences and geography of where you live. But when you are doing the CT, a couple things I want to emphasize is that if you are going to start talking about cartilage invasion, make sure you look at these in very high bone algorithms. Because here's erosion here of the inner cortex. Notice the outer cortex is intact. This is a T3. And on the T4, notice there's erosion of the inner cortex and the outer cortex. And this is a T4 lesion. Again, this is really based on what we see on imaging. On MR, what do we look for? We can look at it pre or post contrast. Either is fine. This was a nice case given to me by Suprita, who we all know. What I like to do is I look at the non-contrast T1 weighted images. Normally, the thyroid cartilage looks like an inverted horseshoe. But in this case, we can see the normal high signal involving the left lamina of the thyroid cartilage. Look at the right side. We can see some bright signal here, but here it's truncated. And this is all tumor here involving the right thyroid cartilage. And on this axial pathological specimen, we can see the tumor extending laterally. So other sequences that you can use are T2 sequences and a T1 with contrast. But for me, I have to admit, I think this is the one I like the best because for me, it's much more simple to look at that replacement. But again, just realize other sequences can be used. The next key element is, does a tumor extend outside of the larynx? This is pretty easy. This is just exolaryngeal spread associated with gross cartilage invasion and extending into the soft tissue. This one I think is pretty easy to identify. This is one that's a little bit more subtle. This was a piriform sinus carcinoma extending into the soft tissues. Again, draw a line down the middle. Notice the normal fat on the left, and we can see this tumor is pooching over to the right and abutting the vessels of the superior laryngeal artery and nerve. And then the last thing I always like to look for is whether or not there's involvement of the anterior commissure. So this is a tumor involved in the anterior commissure, and realize we talked about how these tumors can grow up and grow down, they can grow back, but they can also grow anteriorly. So anytime that I have tumors involved in the anterior commissure, I want to pay especial close attention to the cartilage. So this is a case that I actually referred, I have a joint appointment in radiation oncology. So one of the radiation oncologists sent this to me. They were worried about cartilage invasion. They did an MR, but it was read as negative. And when I draw a line down the middle, compare the right side to the left side, here's the normal true vocal cord on the left. Here's some normal fat on the left-hand side. Notice the heterogeneous fat. All of us ossify a little bit differently, but we tend to be symmetric. Now on the right side, here's the tumor, and notice how this cartilage is replaced. And with the leap of faith, there's actually early exolaryngeal spread. So remember to draw your line down the middle compared to the right to the left. And this was a true vocal cord carcinoma that involved the cartilage and extended into the anterior commissure, and it's actually extended anteriorly into the soft tissues. So they were thinking about doing a laser resection, but now this patient, only surgical options were either going to be total laryngectomy, but in this case, this patient was treated with chemotherapy and radiation therapy. So again, we make a huge difference when we do our analysis correctly. And so what we've done so far is that we talked about anatomy and we talked about squamous cell carcinomas. Now what I'm going to go through is the last 5% of the non-squamous cell carcinomas. And the most common non-squamous cell carcinoma is going to be minor salivary gland tumors, and they account for about less than 1%. The challenge is radiographically, we can't tell the difference. This was an adenoid cystic carcinomas, and this was mucoepidermoid carcinomas. I do not know the difference. The only thing that I have learned in my experience is that if I see a tumor here and the surgeons tell me it's purely submucosal, that indicates to me that it may be arising from a minor salivary gland rest, and it may be a minor salivary gland tumor. Otherwise, unfortunately, I'm kind of at a loss. So if I saw something like this, I would still say squamous cell carcinoma, then follow it up with possibly minor salivary gland. So I don't have much to offer to try to differentiate these. But these we can differentiate. The second one, a common tumor, I should say, that involves the laryngeal cartilage are going to be cartilaginous tumors. So this is an example of a little enchondroma. We can see this expansile lesion involving the right cricoid cartilage, the right thyroid cartilage, and we can see here maybe some rings and circles. I think it's hard to say. And this is an example of an enchondroma involving the right arytenoid cartilage. So when I see something like this, oftentimes we end up picking these up on cervical spine MRIs or cervical spine CTs. That's usually when I end up seeing this. And I'll just mention it's just like a little incidental cartilaginous lesion, probably an enchondroma. But realize you can have malignant forms of cartilaginous tumors. This is the classic example of chondrosarcomas. So in chondrosarcomas, again, you can have this expansile lesion right here involving the right cricoid cartilage. This was, again, pathologically proven chondrosarcomas. And this is what it looks like on MR. Here it is on a non-contrast T1, high signal on T2, somewhat non-specific, but when I see something like this, it's going to be submucosal, and it's arising from the cartilage, and the surgeons tell me it's a little bit firm when they do their endoscopy, then I think it's arising from that cartilage, and I will suggest that diagnosis of a chondrosarcoma. We have some other mesenchymal lesions that can involve the larynx as well too. There can be of neurogenic origin, hematopoietic, or mesenchymal. So this is just an example of a lipoma. This was a lipoma extending into the retropharyngeal space. We can see it's fatty. This is an enhancing hypervascular lesion involving the larynx. This occasionally comes up. And in this case, this was an unusual paraganglioma. So if I do see something that's hypervascular, and the surgeons will tell me it's red, then I can suggest the possibility of a paraganglioma. In this particular case, this was a mesenchymal lesion that had this new bone formation. I can suggest the diagnosis of an osteosarcoma. In this case, it was pathologically proven. It still could be a chondrosarcoma, but with this type of bone, I would raise the possibility of an osteosarc. And this is an example, again, given to me from my friends in Tanzania. The only way that I can even suggest this diagnosis is that there is a predilection for Kaposi sarcoma in certain areas of the world, specifically in sub-Saharan Africa. And in the AIDS epidemic in the United States and the immunocompromised patients before the effective medications, we would occasionally see this. But this is just an example of Kaposi sarcoma. So in these particular instances, we can suggest a diagnosis if we see some fat, if we see something that's hypervascular, if we see new bone formation, or if we're in a geographic predilection. But I would say 9 times out of 10, sometimes you just can't tell the difference, and you have to kind of leave it to a differential diagnosis. So the next thing that we'll talk about are various infectious and inflammatory processes. And I did want to give a shout out to my colleagues in Brazil. I don't know if any of them that are on this talk with Mayra Sarpi, who's now at the University of Florida, one of my prior fellows, is now, we just published this paper. I don't think it's been published in Radiographics or will be pretty soon, on various infections and inflammatory processes of the larynx. So I would refer you to that if any of you all are interested. So when we talk about infectious and inflammatory processes, let's first start off with some of the more common things. So from my standpoint, I don't really read plain films anymore, but if you are working in a pediatric population, sometimes these kids will come in with a barky-like cough. And in this case, what we see is narrowing of the airway. And in the old days, we would call this a steeplechase. Now, I don't know if you still call it a steeplechase or not as residents, if this is what you're taught, but this is the typical appearance due to croup. And this is due to the virus of the parainfluenza. Fortunately, we don't see this very often because a lot of kids are getting immunizations. And get your immunizations. I know it's a big controversial topic in the US right now, but I'm a huge vaccine fan. So get your immunizations. In this case, this is an example of a child that comes in drooling, a fever, sore throat. And back when I was a resident, one time I was in the emergency room, we had someone that came in that we thought may have this, which is epiglottitis. And we were very, very concerned the patient could just clamp off their airway. Fortunately, again, we don't see this very much because people are getting their H-flu vaccines. So we tend not to see this very often, but this is the classic plain film right here, epiglottitis in a child. Now, this is something I just saw a case very similar to this last week, but this is, if you will, epiglottitis in an adult, and we kind of call this supraglottitis. So despite that it's rare in adults, I still see this more than I kind of thought I would, despite people getting vaccinated. But here we have this diffuse thickening, and we refer to this as supraglottitis. So you can think of this as epiglottitis in an adult. That may not be completely accurate, but that's kind of the way that I look at it. And if this gets really, really bad, well, you can go on to develop air and develop a frank abscess. Now, here are some other infectious and inflammatory processes that can involve the larynx. And so what I want to do in this case is go over these, but then we'll talk about how you can make a specific diagnosis. So one of the things that you can see is relapsing polychondritis. Now, this is kind of interesting because I think this is more common than you think it is. Oftentimes, these patients will come in with hoarseness. They'll have the inability to move their vocal cord. When the surgeons look down, they don't see any mass at all, but they'll see a little bump. They'll see a little redness at the level of the true vocal cord. So sometimes they'll biopsy it. I know this patient was biopsied. It all came back negative. It all came back to inflammation. The patient was treated with steroids and they got better. And we assumed that this was relapsing polychondritis. So when I hear that history without any evidence of tumor and they have that vocal cord palsy, I will suggest the diagnosis of a relapsing polychondritis. Occasionally, you can have rheumatoid arthritis involving the true vocal cords. In my experience, it's pretty rare. I think it's secondary to involve that cricoid-arytenoid joint, so it extends anteriorly. This is an example of an amyloidoma given to me by my colleague Martín Ferraro in Argentina, path-proven amyloidoma, really nothing that I could suggest. This is an example of granulomatous polyangiitis. We used to call it Wegener's, and this was sarcoidosis. So again, nothing specific here, but if you do see something circumferential and enhancing, and it's not tumor, and the surgeons come back and say it's friable, but it all came back negative, you can suggest the possibility of something unusual, and these things are granulomatosis and sarcoidosis. So in general, this tends to be the differential diagnosis for inflammatory processes involving the larynx. But you can actually come up with specific diagnosis. So here's an example of a patient that has a mass right here involving the larynx. And when we look at the plain film right here, we can actually see a parenchymal abnormality. And this is sometimes what we refer to as a gnome lesion. When we see this, we can suggest the diagnosis of tuberculosis. How about in this case? This was a case that I saw about 4 years ago. This patient came in, there was just gas in the anterior neck. The patient was immunocompromised, an IV drug abuser, had never had radiation or chemotherapy, and lo and behold, this was a bad case of necrotizing fasciitis. And this is the actual image of this patient, just a terrible disorder. This patient had had chemotherapy and radiation therapy. This is an example of air here, both in this case, the soft tissues anterior to the thyroid cartilage. And in this case, it's involving the cricoid cartilage. And this is an example of chondronecrosis. So when you are treated with chemotherapy and radiation therapy, sometimes patients can develop air in the cartilage. And this is an example of the chondronecrosis. And this is an example of a patient that had this thickening right here involving the anterior portion of the true vocal cords. When we look at the larynx, we see all of these papillomas involved in the airway. And this was an example of laryngeal papillomatosis. So you can make the suggestion right here if you see these inflammatory polyps, and these are HPV associated. So occasionally you can make the diagnosis of some of these specific disorders. Well, the next thing that I want to do is talk a little bit about congenital and developmental lesions. And we'll begin the journey talking about laryngoceles. So when we talk about laryngoceles, we hit the anatomy pretty hard. So this is the aryepiglottic fold. Here's the false vocal cord. Here's the true vocal cord. And right here is the opening of the laryngeal ventricle. So what is a laryngocele? A laryngocele is a dilatation of the laryngeal ventricle. If this dilatation of the laryngeal ventricle is limited laterally by this thyrohyoid membrane, so it's only within the larynx itself, this is what we refer to as an internal or a simple laryngocele. This is interesting because these patients can then be treated by an endoscopic approach. These can be marsupialized. But if we as a radiologist say this laryngocele is now extending through the thyrohyoid membrane into the soft tissues, as we see here on this coronal image, well, this is a complex laryngocele. And I think most surgeons will say this cannot be treated through an endoscopic approach, but it's going to require an endoscopic approach and a cervical approach as well, too. So again, we as radiologists make a huge difference, not only for making the diagnosis, but talking about where it's extending to, because it directly affects the surgical approach. So here's an example of another laryngocele. They can be fluid filled. So this is air filled and fluid filled. And on the coronal images, nicely demonstrating extending through the thyrohyoid membrane. Now, who gets laryngoceles? Well, you can have trumpet players. This was Dizzy Gillespie. He played a flugelhorn. They get laryngoceles. If you've ever been to a glass blower, they get laryngoceles because all of that intraluminal pressure can literally pop open that laryngeal ventricle. But one thing I always want to remind you of is that sometimes the laryngocele is not due to this wide opening that we sort of see here, but sometimes it's due to a narrowing. And that narrowing can be due to a squamous cell carcinoma involving the false cord or the true cord. So this patient presented with laryngocele, and what level are we at? We're at the level of the false vocal cord, right? There's our friend, the arytenoid cartilage. So notice the tumor right here. So anytime that you have a patient with laryngoceles, remember, these patients can smoke or drink. It predisposes them to developing squamous cell carcinomas. So always look very, very closely at this level to see if there's a tumor. So the next thing that I wanted to talk real briefly about when we talk about the larynx, developmental lesions or thyroglossal duct cyst. So remember, the thyroid gland starts at the foramen cecum and then works its way down anteriorly into the neck. If you have the cyst right here located at the foramen cecum, this is an example of a thyroglossal duct cyst. Well, guess what? Here's another thyroglossal duct cyst. So this one is not midline, but it's off midline and it's embedded in the strap muscle. And in this case, this is midline and paramidline, but it's also embedded in the strap muscle, and this is unilocular. So the bottom line is how do I know that both of these are thyroglossal duct cysts? Well, the reason is because it's embedded in the strap muscle. And the reason these thyroglossal duct cysts, when you swallow, is that the strap muscles basically elevate the larynx. They're like the cable shafts of an elevator. So anytime you swallow, these muscles contract. And as a result, these patients will present with an anterior neck mass. And when they swallow, it moves up and down. And the reason is as these muscles are contracting, because this is embedded in the strap muscle, it moves along with the contractions. And so that's how we can make the clinical diagnosis of a thyroglossal duct cyst. And on rare occasions, and I'll say very rare occasions, you can get an incidental papillary thyroid carcinoma. So sometimes you can develop a little tumor here involving the thyroglossal duct cyst. It's most commonly papillary thyroid carcinoma. Sometimes it's mixed papillary and follicular, and occasionally it's squamous cell carcinoma. Oftentimes, these are incidentally seen when these tumors are reviewed by the pathologist, but if you are doing a CT scan and you notice a solid enhancing component, please point that out on your report, because then the surgeon has to be aware and they want to make sure they can get all of that thyroglossal duct cyst. They always try to get it anyway. But if you do see something like this, please point that out. And then the last thing that we're going to end with is the vocal cord palsy. So again, probably if you're in a general practice, this is the most common reason that you're going to specifically evaluate the larynx. So when you are evaluating the larynx, realize on the left, the vagus nerve comes down and the recurrent laryngeal nerve comes off the vagus, extends superiorly in the tracheoesophageal groove, and then innervates the larynx. So on the left-hand side, this wraps around the aortic arch. Now, on the right side, the vagus nerve comes down and gives off the recurrent laryngeal nerve, and it wraps around the subclavian artery on the right, and then it extends and ascends in the tracheoesophageal groove. So any time you have a vocal cord palsy, please figure out what side it's on. And then on the left, you have to scrutinize down to the AP window and then look at the tracheoesophageal groove. And on the right-hand side, make sure you always look down here involving the subclavian artery, and then again along the tracheoesophageal groove. So anatomically, this is your search pattern when you have someone with vocal cord palsy. The next thing is, how do we look at it clinically? So sometimes vocal cord palsies can be confusing. So this is a classical example of a vocal cord palsy here, and notice the left aryepiglottic fold is paramidline. We can see ipsilateral enlargement of the piriform sinus, and this structure right here is an enlarged laryngeal ventricle. So this is the normal appearance of a vocal cord palsy. Now here's a squamous cell carcinoma. I think it's pretty easy to separate this out. We see a big mass right here involving the left true vocal cord. So this one's pretty easy, right? But on the other hand, if you look at this level, what level are we at? I don't see any arytenoid cartilage. We're at the level of the aryepiglottic fold. So this aryepiglottic fold is midline, and you can see it's a little bit thickened, right? And now you're worried about, is this an aryepiglottic fold carcinoma? But look at the laryngeal ventricle. Look at that laryngeal ventricle. It's dilated on the involved side. So this is the classical appearance of a vocal cord palsy. Now look at this patient that has the aryepiglottic fold carcinoma. Notice this thickening of the aryepiglottic fold. If you're not used to looking at this, you can say, well, it sort of looks something like this. But on the other hand, look at the piriform sinus. And notice this piriform sinus is narrowed. So this is suggesting much more mass effect on the left than compared to the right. So this is an example of the vocal cord palsy, and this is an example of an area epiglottic fold carcinoma. Regardless, if you see anything like this, it is totally appropriate to correlate with laryngoscopy because sometimes it can be difficult. But anytime when I see something like this, I always say, this is what I see, and then correlate it with the laryngoscopy. So when we are looking for our vocal cord palsies, again, this is the coronal images to what we look for. Here's the ipsilateral dilatation of the laryngeal ventricle. There's that medialization of the left area epiglottic fold. So this is a left-sided vocal cord palsy. Remember, the 10th nerve starts at the nucleus ambiguans involving the midbrain. And we can have, therefore, involvement here involving the brain, extending all the way down to the mediastinum. Remember, we have to look at the mediastinum. So when I look at the vocal cord palsy, and this comes from my quote-unquote experience, because these are all cases that some of them were missed initially. Centrally, I always want to look at the midbrain, but I also want to look for any Chiari malformation, because I learned about 20 years ago patients with Chiari malformations can present with vocal cord palsies. Typically, they're bilateral paracysts involved in the cord, but sometimes they can be unilateral. So I want to look at the brainstem, and I always want to look for Chiari malformations. This was an unfortunate case. This was a very, very difficult case that was not picked up. And unfortunately, this patient had a left-sided vocal cord palsy. And if I draw a line down the middle, compare the right side to the left side, notice I can see the carotid and the jugular on the right, and look at all the fat planes here on the left. But notice all those fat planes are gone, and you can see there's actually a plaque-like soft tissue right here adjacent to the carotid space. And this was all squamous cell carcinoma involved in the carotid space. And that's why this patient had a vocal cord palsy. So unfortunately, this was missed, and unfortunately, this patient did not do well. But this is one of the tough diagnoses. But remember, look from the side to side, and then always compare the right side to the left side. This was an example, again, of a patient with a left true vocal cord palsy. Now we're down here into the superior mediastinum, and we have a tumor here involving the left tracheoesophageal groove. So remember to look in the tracheoesophageal groove. And then finally, once you get down here to the aortopulmonary window, remember tumors involving the superior mediastinum, or I should say the mid-mediastinum, can also result in vocal cord palsy. So you can see this in lung carcinoma. This happened to be a metastases to the TE groove, but you can have bronchogenic carcinomas involving, giving you a vocal cord palsy. And then on a rare occasion, I know many of you like the spotters. This is an example of Ortner syndrome. So what Ortner syndrome is some type of cardiovascular anomaly. In this case, it's a ductus diverticulum that can pinch off the recurrent laryngeal nerve. And this can give you an ipsilateral vocal cord palsy. And this was described in 1897 by Ortner. And it doesn't have to be this little ductus diverticulum, but I have seen dilated pulmonary veins and other vascular anomalies give you this. So sometimes you won't find the tumor, but sometimes you will find these little vascular anomalies. So for me, this is the search pattern when I go from top going down to the bottom. So what I've tried to do over the last 55 minutes, and again, I want to thank Akshay for the gracious invitation, and Vasu, it's an honor and a privilege for me to share this webinar with you. What I tried to do over the last 55 minutes was talk about the anatomy, and I want to emphasize the big five. So if there's any takeaway from this, remember, please review the 5 components of the larynx, the big 5, right? Hyoid, cricoid, a thyroid, arytenoid, and the epiglottis. Those are your big 5. If you do this, then the larynx is going to be fun. We talked about neoplasms. We primarily focused on squamous cell carcinomas, and I gave you a certain checklist, key elements to include in your report. We also talked about infectious and inflammatory processes, that occasionally we can make a specific diagnosis, albeit it can be hard at times. A little bit about congenital and developmental anomalies. We pretty much focus on thyroglossal duct cysts, predominantly, and laryngoceles just based on time constraints. And then finally, we ended up with vocal cord palsy. So Akshay and Vasu, I'm happy to take any questions. And again, thank you for the honor and privilege of allowing me to give this presentation on this fabulous format. Thank you very much.
Thank you, sir. That was a very enlightening lecture, especially the anatomy with the scopy images and the CT images. So this complex anatomy was really simplified. And after this lecture, I have left with a deeper understanding of the subject. Like transglottic, I used to always feel it is a vocal cord. I never thought it was the ventricle, which was actually, I mean, it was through the ventricle when it crossed. The inflammatory and the infective, I can't, there's some problem with the camera, I can't put it on. The infective and the inflammatory pathologies that I mean, you showed us, it was something that we will see in a lifetime. And we are really looking forward to your article that will be published in the radiographics. And even the vocal cord palsy, I used to never check the skull base for Chiari and or for the vascular malformation in the mediastinum. So this knowledge that you have given us will definitely make us better after hearing to this talk of yours. I'll take up the questions. I was really thank you. Very enlightening talk.
Thank you very much.
So I'll take. I think one of the tumors you showed there, someone is asking why was it not a subglottic carcinoma with a glottic spread? So basic question is how do you decide the epicenter of a tumor in a larynx?
Yeah, I think that's a great question. So I think what you have to do is to basically all tumors sort of have a bulk to it. And I think the early tumors are really easy to see because in general, if you look for those anatomic landmarks, they're there. Once the tumors get really, really big, then what I have to do is kind of think where I think the center of the tumor is and scrolling from top to bottom. And then I just have to mentally manipulate where I think the center is, and that's where I kind of ascribe that tumor to. One of the hardest ones is that if you have a big tumor, so for instance, I can go ahead and do the share real quick. Let me see if I can share it. Yeah. One of the one of the big things that we end up seeing that's really hard is that when we have tumors, can you see my screen? Did it come up now?
Your previous last slide is seen.
Okay, great, fabulous. So one of the hardest ones is that when I have a tumor that's at the junction, a large tumor involving the area epiglottic fold. So I go to the area epiglottic fold one here. The area epiglottic fold is hard because the medial margin of the area epiglottic fold is larynx, and then the lateral margin of this mucosa actually forms the piriform sinus. So this to me is one of the more harder ones to figure out. I would say 9 times out of 10, they tend up involving the area epiglottic fold. If I see this tumor, and I think I did show one case of this, if I see a tumor here that's involving there it is right here, this lesion right here, this is a good example. So where is this tumor arising from? Well, in this case, this tumor is far lateral, and it's actually extending laterally through the thyrohyoid membrane. So when I see this type of pooching, then this tips me off that it's probably a piriform sinus carcinoma. So that's how little things that I've learned over time that help me. I'm not always right, believe me, but that kind of helped me over time.
Yeah, that was really great. Now, regarding 6 glottic extension that you were referring in the craniocaudal direction, I think he wants to know from glottis to subglottis, what is the landmark that you will use?
Yeah, great question. That's a great question. So what I end up doing, let's see if I can articulate this. So at the true vocal cord, if I see a lesion, well, let me put it this way. The nice thing now is that when we are using multi-detector CT, we can do it basically 1 to 2 millimeter thick sections. So what I end up doing is that I look at the axial images, and when I'm basically at what we refer to as the undersurface of the true vocal cords. So there's the thickness or the height of the true vocal cord is approximately a centimeter or so. So what I like to do is scroll down to the most inferior portion of the cricoarytenoid joint, and that tells me I'm at the undersurface of the true vocal cord, and then I just continue to scroll down. And then I'll just scroll down, scroll down, scroll down, and then I'll measure the thickness. So that's how I kind of measure that thickness of the subglottic spread.
Okay, that's great. I will try it now. Next question.
The other thing too, Vasu, is it's important, and I'm glad we have time to do this, is that when you are doing your laryngeal imaging, Again, with multi-detector CT, it's always important that when you are evaluating this, if those of you that are going to be now doing this to look for subglottic spread and transglottic spread, make sure your imaging plane, your MPR plane, is parallel to the laryngeal ventricle. So I didn't really have time to do this because your texts are going to vary. Sometimes the equipment varies, but we all now have the ability to vary our planes. So make sure that plane that you're looking at this is parallel to the level of the laryngeal ventricle. And that's going to help you be more accurate if you are going to get into these very important measurements for subglottic spread.
Yeah, I think I never paid attention to this. From now onwards, I'll take care of it. Then next question is, if the tumor is abutting a cartilage and there is rarefaction, very slight to appreciate whether to tell it is involved or not.
That's a great question. I guess I would have to see an example of what you mean by rarefaction. So from my standpoint, if I have an ipsilateral tumor, so if I look at this case and I see some thinning here of the inner cortex, and on the opposite side, that inner cortex looks pristine, so there's definite asymmetry, then what I will end up saying is that it would be an early T3. So I would call that an early T3.
Okay.
The other way that you can do as well is that in those particular cases, that's where I think MR is a really important problem solver. Because in general, we don't do a lot of MR upfront. But for instance, if the question is, does a patient get chemotherapy or radiation therapy? In general, if you're looking at this subtle rarefaction, in most cases, they're just going to go ahead and give chemotherapy. But on the other hand, if you are looking for this involvement and they're saying, should I treat with non-surgical organ preservation therapy or should I treat with surgery? And they want to know, with much greater certainty whether or not the cartilage is involved, then you can do an MR. Just realize on MR, we know that all tumors have a very robust inflammatory response. So unless we see tumor extending to both sides of the cartilage, like we see here, if we know that this is tumor. But on the other hand, if we see that rarefaction on the laryngeal surface and the outer cortex is intact, and then we do an MR and we see enhancement, we're not 100% sure whether or not that's actually tumor or it's peritumoral inflammation. And that's why the specificity on MR is lower than it is on CT. So I didn't get a chance to go over that again based on time, but I was hoping a question like that would come up just to clarify it.
Yeah. And if it is a non-ossified cartilage, would you like to look at a bone window or a soft window?
Yeah, so that's a great question. So from my standpoint, if it's non-ossified, I don't think CT is very good at all. So as I sort of alluded to, is that as we age, Akshay's cartilage is going to be different from your cartilage and different from my cartilage. But the thing that we do have in common is that all of our cartilages tend to ossify symmetrically. So because of that symmetric ossification, then we can compare one side to the opposite side. So if it's no ossification at all, then I tend not to include in my report whether or not the cartilage is ossified because I know I'm going to be wrong more than I'm going to be right.
Because I think 80% of our patients have non-ossified cartilage. Maybe they present younger. So we never
Yes, that's
tried
possible.
MR.
Yeah. So there's a good option where you could do an MR to see whether or not there's a T2 signal abnormality, whether maybe the cartilage is ossified, or maybe do a T1 post contrast and see whether or not there's enhancement of the cartilage. So I think that could be a very tangible application. But you have to make sure that the patients are rock solid. They have to rock still. They have to be still. They cannot be moving.
Any experience with ultrasound on laryngeal cartilage invasions?
I don't. I know